Good morning. I'm Dr. Stephen Rokito, and I'm a Northwell Health orthopedic surgeon and chief of the division of sports medicine at Long Island Jewish Medical Center. This morning, I will be sharing with you an update on a very important topic, current trends in sports medicine pain management using a multimodal approach. Regarding this presentation, I have no disclosures. As sports medicine providers, we are confronted daily with an array of athletic injuries, some relatively minor and others quite serious. These injuries cause mild to severe pain. Understanding the injury, healing, and the pain process, and when and how we can best intervene is essential for optimal care of our patients. During this presentation, I will review with you the current trend and use of multimodal strategies for pain management. Specifically, we will review common modalities, physical therapy, perisurgical nerve blocks, and pharmacologic therapies. At the end of the review, I will also share with you a typical case scenario. A large percentage of the injuries we see follow the typical ligament injury healing model with the three overlapping phases. The inflammatory phase occurs within the first 24 hours of injury, and this is characterized by the release of inflammatory mediators, increased blood flow, and migration of inflammatory cells to the site. The second phase is the proliferative or repair phase, and this is characterized by an increase in cells and matrix molecules, which start within 2 to 3 days after the injury and continue over several weeks. The final phase is the remodeling and maturation phase, and this is characterized by a decrease in cellularity and vascularity with an organization of the tissue. This can take begin at any time within several weeks after the injury and occur for up to a year. Seen here is the classic pathophysiology of pain flow chart. So trauma occurs to a body part and the local nerves are stimulated with the afferent pathways to our spinal cord and our brain activated with efferent feedback. Interventions at each of these sites with anesthetics and medications will modulate the pain. Modalities are widely used to reduce the pain. This list of modalities is ever growing. Seen in bold are the commonly used modalities in our clinics. So what does the literature and science say about the efficacy of these modalities with regards to pain modulation? Well, you can see the X's here under pain modulation: cryotherapy, thermotherapy, ultrasound, electrical stimulation, iontophoresis, and laser therapy all have evidence to support their use for pain modulation. So let's touch on a few of these. So cryotherapy is the application of cold to a desired body part to drop temperature. We have multiple medias from ice packs to cryocuff devices to achieve this effect. Cold basically causes local vasoconstriction to control edema and reduce pain and muscle spasm. Thermotherapy. Heat reduces pain and increases blood flow and the elasticity of the connective tissues. Typically, we use heat after the acute recovery phase to help with stretching. Electrotherapy, otherwise known as electrical stimulation. Electrical stimulation is delivered transcutaneously with these electrodes placed over the treatment areas. The body serves as the conductor, and current flows between the electrodes, accessing peripheral nerves and muscles. So electrical stim is used for two main things: pain modulation and neuromuscular electrical stimulation, otherwise known as Russian stimulation, is used to help as an adjunct for muscle strengthening. Multimodality treatment. So here you can see, an athlete in one of our clinics, high school soccer player with hip flexor and adductor strains, and he's being treated with multiple modalities. He's getting stem and cryotherapy to the injured areas. This is oftentimes followed by hands-on massage therapy. In this case, the therapist decided to do some active release treatment to get in there, and as well as stretching. And then before he left the clinic that day, they also utilized kinesio tape to the site. Physical therapy, so sort of an extension. Our therapists working with our student athletes in this setting at one of our recover clinics lots of stretching, lots of hands-on manipulation of these sites to help reduce pain and spasm. You can see in the bottom right the addition of a soothing cream to the site in treating a patella tendonitis case. Bracing. Bracing is used very frequently with our athletes when they get injured. Here's a post-op example of bracing, an athlete who had an ACL reconstruction, which we're using a very typical post-op hinge knee brace to help support the joint, as well as to allow for some controlled range of motion. Regional block anesthesia. So when we do surgery, in addition to general anesthesia, the trend is now to use regional block anesthesia. This has been a game changer in allowing our patients to have essentially near complete pain relief for the first 12 to 24 hours after surgery. So this slide is depicting our anesthesiologist giving an ultrasound-guided interscaling nerve block for a typical shoulder operation, whether it be a labral repair or rotator cuff repair. They're giving what's called a interscaling block. This is a block above the clavicle into the plexus, the brachial plexus. It's both a sensory and a motor nerve block. This is an example of a regional block given for lower extremity surgery. We're doing an ACL reconstruction in this case, and the anesthesiologist is giving an ultrasound-guided nerve block, which is primarily a sensory block for post-op analgesia. So the final big topic of this presentation is on pharmacologic management, the basics. Orthopedic surgeons have prescribed the third highest number of narcotic prescriptions among all physician groups, and therefore we have a major role to play in decreasing the use of opioids. Although we can restrict prescriptions, orthopedic surgeries are often very painful, and we use opioid medications and non-opioid medications to help control pain in our patients who suffer athletic injuries, as well as in the acute post-op setting. In order to successfully manage pain, we need to know the basic science behind these powerful medications, understanding their mechanism of action, knowing what oral morphine equivalents are, and knowing what non-opioid drugs can amplify or weaken the potency of these drugs can help us and become more informed prescribers and leaders in helping control the opioid epidemic. So opioids typically are used to control moderate to severe pain. Natural opioids are derived from the poppy plant. Opium is the parent compound. The human body has 4 natural opioid receptors. Morphine, codeine, and thebaine are derived from this parent compound, morphine. So those are considered the natural opioids. The receptors, the M and the D receptors, control analgesia, respiratory depression, and physical dependence. And that's the key. So, there's certainly we're looking for the analgesic effect. However, the common side effects include respiratory depression, and then given in multiple doses, high doses for extended periods of time, there's always the concern for addiction with physical dependence. Kappa receptors, another receptor located in our body, is in the spine, and it produces spinal anesthesia, sedation, and mild respiratory depression. The next large group of opioids are the semi-synthetic opioids. So these are the opioids that are derived from the natural opiates. So these are chemically modified from these natural sources. Heroin, for example, and hydromorphone are derived from morphine, hydrocodone from codeine, and oxycodone from thebaine. Finally, synthetic opioids, these are completely synthetic. These are completely synthesized in the lab. Fentanyl and tramadol are 2 examples. The goal of semi-synthetic and synthetic opioids is to produce morphine-like analgesia with less side effects. So understanding the different types of opioids is important. Understanding where they're derived from. Are they natural, semi-synthetic, or synthetic? But then also obviously understanding the characteristics of each of these is important. How are they metabolized? Are they metabolically active, or do they need to go through metabolic pathways to become activated? Morphine is metabolically active, whereas codeine needs to be metabolized in the liver. This is important as some patients cannot metabolize the codeine, and as a result, they're not going to have any effect from the use of the opioid. When we look at narcotics and we compare them, it's important to understand a concept known as oral morphine equivalence. So again, potencies are going to be different. If we use morphine there as the standard, and we look at some of the other commonly prescribed medications, such as Tramadol, which is a synthetic, you can see that Tramadol in relation to morphine is only 1/10 the potency. So this is important for prescribers, as well as when we're kind of transitioning patients from hospital-based strong medications to outpatient medications that we can give orally. We want to understand the morphine milligram equivalent. So there's through understanding these equivalents and using something as simplistic as a morphine milligram equivalent calculator, we can better understand what the relative doses of these medicines are in relationship to one another. So if I'm sending a patient out after surgery on, for example, oxycodone, which is a commonly prescribed medication at a 5 milligram dose, and we're giving them 2 every 8 hours, a total of 6 doses, that's 30 milligrams of oxycodone. Where does that fall in the spectrum of morphine milligram equivalents? Well, given that ratio that you can see in the chart on the left, that will equate to about 45 morphine milligram equivalents per day. Another medication that we frequently prescribe is Tramadol. Tramadol, as we know, is less potent. So if I'm going to send a patient out on a regimen of Tramadol at 50 milligrams per dose, and we're going to give them 1 every 8 hours, that equates to 150 milligrams of Tramadol. Using our ratio there, we can see that that equates to about 15 morphine milligram equivalents per day. So a significantly less amount of overall morphine, safer dose, probably better for controlling our patients' pain in the long run with less risks of adverse side effects. Non-opioid medications can impact opioid potency. And this is an important thing to recognize when we're prescribing medications. As I said, the majority of opioids are metabolized in the liver by the cytochrome enzyme systems. There are many common medications also metabolized by the liver in the same enzyme systems. The potency and effect of these medications and the opioids can be affected when given together. So patients may have difficulty with pain control, overdose, or other medical complications and need to be monitored closely. So you can see in these 2 lists below examples of select inhibitors and inducers of these cytochrome enzyme systems. So again, very important to understand the list of medications that our patients come in on when we're prescribing opioids. Moving on to non-opioid alternatives. So biggest group of non-opioid alternatives that we're commonly aware of and frequently prescribed are Nsaids. Nsaids are non-steroidal anti-inflammatory drugs, block the formation of thromboxane and prostaglandins by blocking the cyclooxygenase 1 and cyclooxygenase 2 enzyme, respectively. They work to decrease inflammation and pain. They decrease platelet aggregation, which increases bleeding time. The benefits are they're non-addictive. However, they do carry an adverse effect profile of the potential for increased risk for GI bleeding, and they've been implicated in an increased risk for MI, stroke, and thrombotic events. We need to use these sparingly in our patients with renal dysfunction. We're all aware of the commonly used Nsaids. When it comes to Celebrex, this is a selective COX-2 inhibitor and this can be beneficial in patients with GI problems. COX-2 inhibitors have been implicated in increased risk for thrombosis, stroke, and MI. Additional non-opioid alternatives, which we frequently use nowadays, include gabapentin and Tylenol. Gabapentin is used for neuropathic pain control, but it has been shown to decrease pain in the acute post-op setting. Tylenol is a CNS COX inhibitor. It reduces pain and fever. It can affect the endogenous cannabinoid system. Unfortunately, it is hepatotoxic, and we have to be careful in patients with issues with their liver, as well as be careful regarding dosing of this medication. So here we get to a live case scenario, a typical varsity high school football player with an acute ACL rupture and MCL tear. So what I like about this slide is we've kind of summarized the entire presentation right here in one slide. What are we doing with a case like this? He comes in, he gets injured, his knee is swollen. We're going to start with pre-op rehab, otherwise known as prehab, right? We're going to decrease his pain and swelling and optimize range of motion and function in preparation for reconstructing his ACL. So we'll start by using modalities, cryotherapy to help reduce swelling. We'll get him in some physical therapy to help restore range of motion. We'll give him some anti-inflammatory medication to help control pain. When it comes time to surgery, we're going to use regional block anesthesia in addition to general anesthesia to give him nice pain relief within the first 24 hours after surgery. And then we're going to use pharmacologic pain management with a regimen of combined medications. So in orthopedic surgery, there's been a recent trend towards combining these different medications to produce the most effective pain relief. In addition to improved pain management, this combined approach has allowed us to reduce our need for opiate use and obviously decrease the associated side effects of opiates. So you can see this is a typical pain medication cocktail we're using. It's acetaminophen, gabapentin, tramadol, meloxicam, and then the oxycodone. They are getting a supply, but it's a relatively small supply to be utilized only for breakthrough pain. After surgery, we'll utilize modalities in home as well as in physical therapy to help reduce their swelling and decrease their pain. Bracing is commonly used as well to help support the recently operated joint to allow for soft tissue healing in a controlled and increase their range of motion in a controlled fashion. So the goal here, obviously, is if we look at that VAS pain score, is to try and keep them at not necessarily the no pain, that's our goal, but to keep them at that low level end of the spectrum. And with this combined multimodal strategy, we're oftentimes very successful. Thank you.